Hello and welcome to today's webinar, Rare Disease Pharmacy Center of Excellence, version 3 certification. My name is Joe Moore. I'll be your host, and I've been a pharmacy reviewer with URAC since 2021. During our time together today, I want to spend just a few minutes providing some definitions and an overview of rare diseases and the Rare Disease Certificate Program. But the bulk of our time is going to be spent going through each of the standards and elements within this program. I want to make sure I discuss the intent of each of those and what's required to demonstrate compliance with them. And as we go through them, I'll do my best to provide some reviewer tips that might help your application experience be more successful. Let's start by talking about what a rare disease is. And you can see from the information on the slide that rare diseases are called rare simply because of their epidemiology and their occurrence or their prevalence within a population. And because they were so rare, there wasn't much incentive for drug companies to develop therapies or treatments and cures for these rare diseases. They became known as orphan diseases. But that led to governments around the world to try and incentivize these drug companies to put some resources towards cures and therapies for rare diseases, which led to the need for strict definitions of what is and what is not a rare disease. And you can see some of those numbers here on the slide, both here in the United States as well as around the world. So let's start with the definition of an orphan drug, and it's very straightforward. It's simply a drug or medication that's used to treat a rare disease or a rare condition. And that's important when you look at the eligibility criteria for pursuing the certification at URAC. So as we'll talk about throughout this webinar, the Rare Disease Certificate Program really grew out of the patient management standards in the specialty pharmacy program. So the first thing that you need to do if you're an organization is you have to either have a accreditation for one of the programs that URAC offers that includes specialty patient management, specialty pharmacy patient management, or you have to be actively applying for one. So that's the first piece of eligibility. The second one is that of the medications that you're dispensing, at least one of them has to be a medication that carries a rare disease or an orphan disease indication and does not carry any other indications for non-orphan or non-rare diseases. So said a different way, you may have diseases or you may have medications that are in your rare disease program, and those medications may be used to treat not just rare diseases but other diseases as well. It's okay to include those in your program. However, there has to be at least one medication in your program that carries an indication for an orphan disease, and it does not carry indications for non-orphan diseases. So I mentioned this earlier, and we're going to talk about it a lot, but you can see that the standards for the rare disease program really grow out of the URAC Specialty Pharmacy Accreditation Program. And URAC's been doing specialty pharmacy accreditation since 2008 with over 600 accredited specialty pharmacies. The Rare Disease Certificate of Excellence program was first made available in 2020. And as you can tell, we're now on version 3, or our third iteration of those standards. We've got 24 organizations that have successfully earned that certification. So before we get into the standards themselves, I want to talk about some common documents for submission. And this is language that you'll see in the guide. It's language that I'll be referring to. And as you can see on the slide, that for each example of the kinds of evidence that may be asked for in the guide, there's some more details about those. I want to call out just documents for a moment. That's the one that's all the way on the left of your screen. So documents do not necessarily have to be a formal policy for your organization. It could be an SOP, it could be a workflow document or a job aid. What's important is that these are formal organizational documents. These are going to be employee facing, that your employees have an expectation that they know where these are, they know what they say, and they're expected to adhere to them. So that means that what we cannot accept would just be a narrative document. So just something that you may create for the purposes of this review, just to describe how you're doing something for the reviewer. So make sure that any documents that you submit, if the guide asks for a document, is going to be a formal organizational document. Similarly, I want to talk a little bit about some of this common language. And so you'll see in the guide that the document that's asked for will either need to describe a process or outline how. If the guide says to describe a process, that means that the URAC reviewer is going to be looking at the documentation you submitted to see that they know exactly how you're getting to that endpoint or to that outcome. So who is doing it? What are they doing? How are they doing it? When are they doing it? Where is it being documented? So really put all that detail into it so that as somebody with no knowledge of your organization, I can pick up that document, I can read the section that you've cited, and I can tell exactly how it is that you're performing whatever it is that the standard's requiring. On the other hand, if it says outline how, that doesn't require quite as much detail. So outlining how is just a mechanism. It might just be one of those elements that I've listed, just the who or the what or the how or the when. So it's a big difference between describing a process and outlining how, and you'll often get feedback from your URAC reviewer if not enough detail was submitted in your original document. Okay, so that's it for the overview. Now I want to get into the standards and the elements. We're going to go through them one at a time. And what's important to note again is that these standards are coming from the Specialty Pharmacy Accreditation Program. And I'll do my best to draw that connection as we go through each one. So the first standard, RDPM1, is looking at your patient management program overview. So really this is asking you, how have you structured your rare disease patient management program in terms of the personnel and in terms of your risk management? So let's look at the elements that make up this standard. So the first one talks about a designated team, and you can see we've got A, B, C, and D here. So for A and B, the first thing I want to call out is that it requires the organization to provide documents that require you to do the activity that's in A and B, whereas with C and D, it requires you to outline how. So it's a different level of evidence required for A and B versus for C and D. So let's take them one at a time. So we'll talk about A first. So the first thing is saying that, the first thing is asking you, how are you as a pharmacy making sure that you're coordinating with the manufacturer for each drug or disease state that's within your rare disease program? And so this sometimes is a single individual who might be the one that's liaising with the manufacturer at a frequency that could be different from one manufacturer to another, but they've got a relationship with the manufacturer. They have access to the resources that the manufacturer might provide, and they of course can bring that information back to the organization. So along with some documents that are requiring you to assign one or more people to this role, you also have to provide evidence to show that you've actually done this for one of your disease states or one of your rare disease medications that are within your program. Now, similarly for letter B, this is not an individual or group liaising with the manufacturer, but this is talking about your actual patient care team. So some things to think about here are, what are the roles that are assigned within that team? So it might not be appropriate to give me the actual name of each person when you're submitting your evidence, but it should be clear that on your patient management team, this is the expertise that's represented on there. These are the kinds of people, the kinds of roles that are going to be on that team. And it's the same as A document that's going to require that you do that for each rare disease or for each rare medication that's in your program, and then also evidence that you've done it for at least one of your rare disease programs or your rare disease medications rare diseases or rare disease medications that's within your program. One thing to note here is that you may have a rare disease team that covers more than one rare disease. That's totally fine. It's up to you to determine how you want to deploy your resources and how you want to structure these teams. But you need to make sure you've got at least one person that's responsible for coordinating with the manufacturer, and then you have to make it clear who's on the team that's providing care to your rare disease patients. And then letters C and D take that a step further and say, okay, you've got your team, you've told me who's on your team, but now how are your patients able to communicate with that team? And you both have to say how they're doing it during regular business hours for letter C, and then after regular business hours for letter D, with an important caveat. So for letter C, it's saying you've got your rare disease patient care team. If a patient needs to get a hold of them, how are they doing that? Now, this is an outline how, remember. So I don't need the who, what, when, where, why, how for this. I just need some of that detail to understand that you've got a process, whereas people that need to talk to their patient care team during regular business hours, they have a way that they can access them. For D, we're talking about after hours, and it's not the requirement of the standard that your patient care team necessarily is on call after hours. However, what is important is that these rare disease patients, just given the level of specificity and the uniqueness of their disease and what their care may require, after hours, there has to be at least one individual that's been trained in their rare disease or in their rare disease medication. So that way, after hours, if they can't get a hold of their patient care team, there's somebody that they can talk to that can either assess that patient or triage them appropriately. The next element talks about staff education, and here we're going to want to see how you want to see outlining how you're doing it, and then evidence of what you're using to execute this training. So the first one, letter A, is talking about how you're giving specific rare disease training to employees in accordance with their job function. So remember, in the last element, I asked you who's on your patient care management team. Given whatever their role is on the team, there may be a different level of training that they need. So if somebody's more in operations than in clinical management, they may not need quite the same training that somebody who's responsible for assessing and performing interventions on behalf of the patient may need. So it's up to you to determine who's on this team that's getting the training, what training are they getting, but it has to be specific to the rare disease in which they are a member of that patient care team. And your outline of this process should include the frequency of the training and exactly what topics are being covered. And then, of course, I'm going to want to see some example materials to show me what you're using to provide this training. Letter B is a bit broader. Letter B says that you have to make sure that anybody in your organization that may have direct patient care responsibilities, how are they being educated on the skills they may need to understand the patient's journey and engage in an ongoing relationship with them? And the guide provides some examples of what this training may encompass. But just be thinking about, again, these rare disease patients that might have had a very complicated journey to get to your pharmacy with their diagnosis and with their medication order. Is it clear that everybody that may be interfacing with them within your organization has been trained to have the proper sensitivity and communication skills to be able to assist that patient? So same thing, who's getting this training? What training are they getting? How often are they getting it? Those are the kind of information that we're going to look for in your documentation. And then an example of what it is you're using to provide that education. During the on-site visit, this will be part of the personnel file review, where we'll look to see evidence that this training, as described in the documents you submit on the desktop, we want to see evidence of you actually having tracked participation in those trainings. The last element within our DPM 1 is medication risk mitigation. So this builds off of what's in our specialty pharmacy program standards that says you have to do proactive risk assessments. With rare diseases, once again, and I've said this a lot already, I'll probably continue to say it, because of the unique challenges that rare disease patients and rare disease medications may present. This standard is asking for a little bit more than just what the proactive risk assessment is requiring in the specialty pharmacy standards. So here, what we're saying is that for each rare disease medication within your program, you have to have a process that allows you to identify risks that might be associated with the storage and handling of that medication, both in the home, so once it gets to the patient, but also during transport. So how you're packing the medication in your own pharmacy for your packing and shipping procedures to get it to the patient. So you've got to make sure you've got some process where you're identifying what risk may be involved here. But you've got to take it one step further, because you also need to, if you do determine that there's a risk, come up with a mitigation strategy. So what is it that you're going to do to help alleviate or mitigate those risks that you've identified for your rare disease medications, both in the home and during and in transit in terms of storage and handling? Sometimes this involves interfacing with the manufacturer. So this is, again, calling back to 1-1A, where you've got somebody who's in that role where they can coordinate and talk to the manufacturer, because you may need some assistance from them to understand how to mitigate some of those risks, or even what the risks are in the first place. And so you're going to have to outline how you're doing this, and then provide evidence for at least one of your rare disease medications that shows that you've documented that risk assessment, and you've also documented any mitigation strategies that came from that assessment. On site, we'll ask for evidence for up to 3 rare disease medications for mitigation and risk assessment. Okay, our next standard, RDPM2, rare disease assessments. Now this is going to build off of what's in our specialty pharmacy standards as far as patient initial assessments and reassessment. So it's important to remember all of the standards and all of the elements and requirements for initial patient assessments that you're adhering to for specialty still apply to your rare disease patients. So there's 7 elements that have to be represented when you are assessing a patient in specialty. You still got to do those, but we're going to add some additional ones here for rare. Same thing when it comes to reassessments, and we'll talk about that in just a couple minutes. So your rare disease patient initial assessment, again, you're going to make sure that a qualified clinician is assessing the appropriateness and safety of this medication for the patient prior to the first fill of that medication. You're going to be using all of those elements of assessment that were outlined in the specialty pharmacy standards for the initial patient assessment. But to those, you are going to add these 2 elements. The first is an assessment of the patient's journey with the disease, the diagnosis, and prior treatments. So let's talk about that for just a moment. The patient's journey is different than just the past medical history. So these patients with rare diseases, and it's different from one disease to the next, but patients with rare diseases sometimes could have a very complicated and convoluted path where it may take years for them to get the right diagnosis. They may have had other diagnoses, they may have been on other therapies, they may have been in clinical trials. Who knows what they had to go through before they could get the proper diagnosis and get the medication order where they're now at your pharmacy. What's important is not simply that you're documenting what the journey is. So not just here's some other diagnoses that they had, or here's some other medications that they tried. The journey is saying, what was the patient's experience with all of that? And there's lots of different ways that you can assess this. So your clinical team will come up for what's the most appropriate way to gather this information and document it for your patients, given the rare disease or given the medication that's within your program. But what's important is that you have a process to be able to document that. And sometimes the patient may not have a very remarkable journey, and that's okay, but that's something that's worth noting in your assessment. What's important is that you as a clinician are including that journey in your assessment, because it can oftentimes really influence how willing a patient is to be a participant in their own care, just given what they've already gone through to get to this point. So it's important that you're assessing that and that you're documenting that. We also want to see barriers to access of successful treatment. So this could be anything that you want to define as a barrier. It can be financial. It also could be adverse drug events, because remember, there's going to be limited agents for some of these patients with their rare diseases. And so an adverse drug event might not be as simple as, well, just switch them to a different agent, because there may not be anything else. And so there's different things that could qualify as a barrier. And again, this is something that within your clinical workflow, within your clinical process for how you're going to manage and treat these rare disease patients, you'll spend some time thinking about what are the barriers that we want to make sure we're assessing for during this initial assessment. So you've got to describe the process. And remember, that's who, what, when, where, how. So you want to make sure you're answering all of those questions for how a qualified clinician is performing this initial clinical assessment prior to the first fill to include these elements within the rare disease standards. And then you want to give us a sample. It can be a redacted actual sample of a documented patient assessment, or most often we just get blank templates where you'll cite that this is the space where I'm going to be able to document the journey. This is where I'm going to document the barriers. And so you're going to upload a sample with some citations for us. So that's the initial patient assessment. And again, it builds off of the specialty patient assessment. Then you can see the rare disease assessments. And so just like specialty pharmacy, we want to see that these patients are being reassessed by a qualified clinician no more than 12 months from their previous assessment. And just like I said for the initial assessment, you want to make sure that those 4 required elements that are part of the specialty pharmacy standards, that those are being included in your clinician's assessment of your rare disease patients. And to that, we're going to add 4 more. And so we're going to go through these one at a time. So patient-reported outcomes, let's start with that. This is going to sound pretty obvious, but to be a patient-reported outcome, it's got to be patient-reported. So it's got to come from the patient. It's something that they are telling you, and it has to be an outcome. So it's something that's going to be an outcome affiliated or associated with their rare disease. Some examples of this that we include in the guide could be a clinical outcome scale, could be a symptom burden, a quality of life, adverse events, right? Something that when you're asking the patient, they're able to give you a report on what those outcomes are. The second one is patient experience. Now, this is different than patient outcomes. Patient experience is sort of more of how the patient's feeling with the medication. So how do they perceive this medication is working for them? Or how do they perceive the services that they're getting from your pharmacy? So those are two distinct things. And it is important that you call out in your process and in the sample that you provide how you're going to be assessing and documenting each of those. Because later on, when we get to PM 5-1, we're going to talk about how you're going to use some of this information when it comes time to evaluate your overall program. So be thinking about what are the outcomes that are most relevant and of the most value to us assessing these patients for their rare disease, and then what are some of the ways that we can get at how their experience has been. The severity of adverse drug events experienced by a patient, this builds off of the requirement to just document whether or not adverse events were experienced by the patient, because here we're saying give us some more detail about what the severity of them are. And then barriers to access or successful treatment, this is staying just like it was for initial assessments. So every time you reassess a patient, you're going to go back and look at what barriers may exist. So those are the 4 requirements. Same thing here, a process, and then an example, redacted or just a blank template that has a citation to say, here's where I'm going to gather each of this and all this information. All right, Rare Disease PM 2-3 talks about individual patient reporting. So this is talking about not overall trends of your program. This is talking about individual patient reporting. So what it's saying is that you're going to have this data that you've gathered through those assessments that we just went over. You're going to have trended data on the patient-reported outcomes, on the patient's experience, on their adverse drug events and the severity of them, on their barriers to treatment, right? That information is going to change and be updated every time you talk to them. You're going to get an additional data point. What this element is saying is that you need to define how and how often are you sharing information with the patient and what information are you sharing. So this doesn't have to be done as a written document. So this is not saying, yes, you need to have a printout and a graph that trends everything and you have to mail it to the patient or email it to them. You can do that. That's perfectly suitable and that would meet the intent of this standard. But this can also be verbal. So there's nothing that says in the standard that this can't be done as part of the discussion you have with the patient when you're interviewing them as part of an assessment. But what's important is that you're defining, again, what information are you sharing with them? How often are you sharing it? And how are you sharing it with them? And you need to define those for this first element for letter A. When it comes to B and C, these you don't need to define when you're doing it because the standard says you're going to do it when it's requested. But this is talking about how often are you sharing information with a prescriber and how often are you sharing information with other pharmacies. So again, you're outlining how you're doing this. So be thinking about what information is it that I'm going to be sharing. And this is, again, patient assessment data, right? Trended patient assessment data. So what information are you sharing to these organizations, the physician and a pharmacy, prescriber in the pharmacy, and how are you sharing it? And this is outlining how. So I don't need the full process. Just one element of it, just a mechanism to know that you've got a system and you have a way that you're doing this. Okay, that brings us to our next standard, RDPM3, Rare Disease Education and Support. This builds off of a lot of what was in the patient services and communication standards within our specialty pharmacy program. And you'll see here highlighted on this screen, reliable information. We're going to talk a little bit about what reliable information is on the next slide. And here we are. Provides reliable information to patients and caregivers when requested. So remember in the specialty pharmacy standards that there's this requirement that you're going to provide education to the patient on their medication. And that's essentially all the counseling points that might be in over 90 that most pharmacists are comfortable with and they're going to do for every dispense. This is now saying, okay, we're not talking about just providing education upon dispensing a medication. What we're saying is, upon request, if a caregiver or a patient wants some additional information, how are you providing information to them? And how do you know that the information you're providing is reliable? And when we say reliable information, what we mean is that this information has been vetted by somebody within your pharmacy to know that this is up to date, that it's accurate, and that you can share it with the patient. So all 3 sub-elements here, so sub-element 1, 2, and 3 underneath letter A, they all need to be met in order for this element to be met. And you've got to describe a process here and then provide an example. And so those three sub-elements, the first is talking about patient community support specific to their disease state. So when we say community here, we don't mean geographic community. We're not saying, okay, well, what's in their town necessarily that they may be able to go use to help get some support for their disease state. What we really mean here is how can they connect with other individuals that are living with the same disease that they are. And so are there support groups, maybe virtual support groups that they might be able to connect with? So how are you providing information regarding those different community resources that that patient can have access to? The next one talks about rare disease and therapy registries. This is really important because this allows patients to maybe have access to nursing resources or other benefits as long as they're part of the registry. So making sure that you've got the correct information to how to connect the patient to that registry is very important. And then available support for caregivers is pretty straightforward, but these caregivers of patients, they're going to have some needs as well for information, or maybe also for community support. And so again, how are you making sure that the information that you provide to them is accurate, it's been vetted, and it's fair and to share with patients and caregivers when it's requested. All right, the next standard, RDPM4, talks about rare disease care team collaboration, and this is going to highlight some of those unique challenges that orphan drugs may present that I was talking about way back when we started this webinar. So let's look at these. Elements. So the first is talking about coordinating patient care, and then again, it has three sub-elements. You want to make sure that for each of these sub-elements, you're meeting the intent of the standard so that you'll get credit for the whole element. So they all need to be met. The first one is talking about collaborating with the manufacturer or hub to coordinate patient care services. So again, we've seen this come up a couple of times now, but it has to be clear that you've got a connection with the manufacturer so that if they are offering any kind of patient care services, that you've got a way to connect with them and that you can coordinate with them to make sure that you can pass those along and deliver those to your patients. The next one's talking about referring patients to alternative support services now provided by your pharmacy. When you're assessing patients, things may come up. For example, maybe the patient maybe they lost their job or they went through some other major transition in life and they might need something like psychological support or emotional support, things that you as a clinician can assess that they need, but maybe it's not within the scope of services that you offer your patients. What this element is saying is that do you have a way to coordinate care with whatever entity might be able to assist that patient? So how would you handle those situations where you identify a need for a patient that's outside the scope of what you yourself can provide for them? And then lastly is providing medication during pharmacy emergencies. The business continuity plan that's in the specialty pharmacy standards covers most general scenarios, but this again is talking about rare disease medications and those unique challenges that they may pose. You may be the only pharmacy in the country. You may have a limited distribution contract to dispense this medication. So if you're hit with an emergency that might shut down your dispensing activity, how are these patients going to get access to this medication? And so you need to make sure that you've got a process and that you're outlining that process for how you're going to be able to provide access to medications in the case of an emergency. And be thinking through each rare disease medication or each disease state that's within your program, right? Within your clinical process or within your workflow for that, this is something that should be considered. And so make sure you've got some documentation that talks about how that you're able to outline exactly how you're doing each of these three sub-elements within this RDPM 4-1A. Okay, now we get to 4-1B. Here we're talking about coordination of care still, but now we're going to outline or rather list for you some specific scenarios. And again, all four of these sub-elements have to be met in order for the element to be met. So remember that these transitions of care that a patient might go through here might be a little bit more cumbersome for rare disease since there's not as many pharmacies out there that are doing rare disease. So as you can go through each one of these. So if a patient's going from a clinical trial to your pharmacy, that's a whole different experience for that patient. How are you going to coordinate care? And you're talking about continuity of care. We're talking about preventing a gap in therapy. What's that experience going to be like for the patient if they're transitioning from a clinical trial to your pharmacy? If they're going between payers, so for example, if a patient changes employers and now they have a new payer. Well, what if you're not contracted with that payer? Or what if the PBM requires a brand new prior authorization? How are you equipped to be able to handle those scenarios in which now there's a different payer that has a different, that you may have a different relationship with, or maybe the patient has to go to a different pharmacy. The next one talks about facility therapy administration and pharmacy and at-home administration. This could be a clinical trial or it could just be inpatient to outpatient. So that's another scenario you need to make sure that you're considering. And then lastly, a change in pharmacy. So this would just be a straight up transfer. How would you handle that, right? Again, they might not be able just to go to their community pharmacy down the street from them as they may with other medications that they need to have transferred. There may be more steps to that. So be thinking about that. And this is going to be unique for each rare disease drug in each medication in each rare disease state. So be sure that your document outlines how, so not a full process, just outlines how you're going to do this. And that brings us to letter C of this element. C says that the pharmacy clearly represents itself with any interactions with outreach programs. This could be things like community walks. It could be support group meetings or conventions. This is more of an ethical consideration. So how are you ensuring that when there are representatives from your pharmacy attending one of these community outreach events, how are you making sure that those individuals are clearly representing themselves as being from your pharmacy, as opposed to maybe soliciting business under some more unsavory or unethical methods? So we just want to make sure, the standard wants to make sure that you've got a process in place and you're just going to outline how you're making sure that for any community outreach effort where you've got representatives from your pharmacy, they're clearly representing themselves as being from the pharmacy. Okay, and that brings us to our final standard, RDPM 5, and this really builds off of the specialty pharmacy program evaluation, and it's going to add some of those elements in that we talked about earlier as part of the patient reassessment. Okay, so annual rare disease patient management program evaluation. So what this is saying is that at least once a year, you're taking a step back, you're looking at this rare disease patient management program that you've designed and built, and you're going to make an evaluation of this program to know, to make some assessment of how that program's been able to be effective and provide value to your patients. This is calling back to that reassessment standard. So remember, barriers to access, we saw that in both the initial assessment and the reassessment. Patient-reported outcomes was part of the reassessment, as was patient experience. So you've got a way to be able to collect this information and document this information because you had to as part of your assessment process. Now what we're saying is you've got to aggregate all that data and look overall at your patient management program and look at this data to determine whether or not to make some evaluation of your patient management program. This too is going to be in addition to all of the specialty pharmacy accreditation program requirements. So you're going to want to make sure that you also have clinical outcomes, financial outcomes, health-related quality of life outcomes, clinical intervention outcomes. But in addition to those, you're going to add these three elements. What's required here is that you define the data. So it says barriers to access, or it says patient-reported outcomes. What data are you using that's going to meet that criteria? And so you want to be thinking through, or you want to be looking back to how you've designed your patient assessments within each of your clinical processes and workflows so that you know what data you're going to have available to you, and then what's the one that you want to pull forward to be able to use as part of this evaluation of the program. Got to do that at least once a year. They're going to define the data you're using and then provide an example, a blank template or an actual sample if you've done one, to show how you are documenting this evaluation. All right, and then our DPM 5-2 is data sharing, and this talks about sharing patient management program aggregate data to external parties. So before we talked about how you're coordinating with pharmacies and how you're coordinating with prescribers on individual patient issues. This instead is talking about that aggregate data from your program. So pretty much could be the same data that you just pulled to do your annual program evaluation. But this is when you may have a contract that specifies that you share that data to these external parties. And so even if you don't necessarily have one of those agreements in place, this element can't be scored as not applicable. So what you want to do is make sure that you're able to outline how you would do this. So what information do you have? What mechanisms are out there for you to be able to share this information if you are required to do so by contract? Okay, that's all the standards and all the elements. What I want to do now is just highlight some of the application resources that are available to you. So certainly if you're in the application process, your client relations manager, your URAC reviewer, they're going to be your primary point of contact. You can reach out to them directly. You can also use the interpretation portal that you have access to through the client portal if you are an applicant or a currently accredited organization. Certainly the guide. So the guide has all the information that I just went through. So making sure you're using each of those. But there's also other educational opportunities similar to the one that I'm recording right now. There's other webinars like this on the URAC client portal. So you can get to the interpretations portal there where you can ask questions. You can also seek out some information on your own or use the direct resources of a client relations manager or a pharmacy reviewer. Here's some information on the slide if you want to get in touch with anybody at URAC. Also encourage you to follow us and connect with us on any of our social media channels as well. That's it. Thanks so much for your time. I hope this was helpful.